Hello everyone, my name is Dr. Amrish Krishnan and I'm a nephrologist based in Fiji. Firstly and most importantly, I'd like to thank the International Society of Nephrology for giving me this opportunity to be able to talk about Fiji and the Pacific and the work that we've been doing over there. I work in a gorgeous country with white sandy beaches and beautiful people, amazing culture and cuisine. But I also work in a country which has had many challenges with healthcare delivery. There are many Fijians who are struggling in poverty.
What makes it worse is that Fiji is also constantly suffering the effects of climate change. Rising sea levels, bleaching of our coral, loss of marine life, and catastrophic natural disasters such as Cyclone Winston, the most intense tropical cyclone in the southern hemisphere on record, continues to affect our economy, the most significant determinant of health. According to the Fiji Ministry of Health and the World Health Organization's NCD Risk Factors and Steps report, a third of Fiji's adult population are obese, 31% have raised blood pressure, and 29.6% have raised fasting blood sugar. And according to WHO's NCD Country Profiles 2018, NCDs are estimated to account for 84% of all deaths in Fiji. In 2012, we looked at the incidence of end-stage kidney disease and discovered that the rates were alarmingly high, among the highest in the world. Based on the estimation of eGFR using the CKD-EPI formula, incidence was calculated to be 938 per million. This means that every year, for a population of around 900,000 people, we have 830 cases of end-stage kidney disease.
This is not surprising because according to the International Diabetes Federation, the Western Pacific accounts for 37% of all diabetic cases in the world.
Astronomical out-of-pocket expenditure has been a major deterrent for patients wanting to access kidney help. Many patients generally prefer not to travel long distances, sometimes via sea, to visit specialists even when they have advanced kidney disease. When they eventually do start dialysis, many patients struggle to pay for dialysis, leave alone kidney transplant.
Our study in 2012 showed that due to a combination of the cost of dialysis treatment and access to dialysis facilities, only 10% of those needing dialysis commenced treatment. The vast majority were offered palliation, which at that time meant home-based care only.
And among the 9 out of 10 who couldn't afford dialysis treatment, there were occasionally children and young adults. The annual Fijian Nephrology Symposium, which was always supported by the ISN, became the platform through which we were able to educate our dialysis nurses, our general medical nurses, our young doctors on how to look after people with advanced kidney disease and those on dialysis. It was also the platform we used for advocacy. So for the first time, our national leaders and politicians became aware of the overwhelming burden of kidney disease in our country. So one of our proudest achievements has been the training, recognition and the vocational registration of Dr. Yogeshni Chandra. Dr. Yogeshni now works in a large public hospital in Fiji where she's able to impact the lives of thousands of Fijians.
I first heard of the ISN Fellowship Program during a nephrology symposium in Fiji in 2015, where Professor Peter Kerr presented on the fellowship program. The application process for the fellowship program took a bit of time with a bit of paperwork and authorization from our authorities for me to actually go overseas for the training. But we were able to do that all in time, and I ended up in Christchurch in June 2016. The nephrology department there, of course, was, and the health system overall was quite different to what I had been used to in Fiji. However, it was a very good learning experience. And the whole team was quite helpful and ensured that I learned quite a bit of clinical nephrology. I finished my training in June 2017 and returned to Fiji and have been working in Lautoka Hospital since. I feel that if it wasn't for the fellowship program, I wouldn't be in the place I am in my career at the moment. So I'd like to thank ISN for the opportunity.
Apart from Dr. Yogeshni, we have been able to support the training of several nurses and technicians. For the first time since the early 2000s, we have, apart from over 20 trained hemodialysis nurses, 2 trained peritoneal dialysis nurses who have been instrumental in the overseeing of PD to Fijians and other Pacific Islanders. These nurses were trained via the Cross-Regional Education and Exchange in Dialysis program conducted in Brisbane, Australia, and during trainers' visits to Fiji.
I remember about 5 years ago when we tried to set up our intensive care dialysis, we didn't have dialysis machines. And with the help of one donor, we were able to get two, not brand new, but used dialysis machines. Even with those two dialysis machines, we significantly changed AKI outcomes for patients admitted in the ICU. We strongly supported the ISN 0/25 initiative. In the recent years, through the ISN Sister Renal Center program and through trainers who have come from overseas, we've been able to learn how to do these complex procedures such as inserting tunnel catheters and doing kidney biopsies. The ability to do kidney biopsies in the recent years has significantly changed our approach to the management of chronic glomerulonephritis and autoimmune conditions like lupus. No matter how trained people get, they're helpless without the right tools, equipment, and resources.
Fiji has struggled with supply chain management and procurement of consumables for decades. The delivery of kidney health has often been hampered by lack of urine dipsticks and laboratory reagents to measure serum creatinine and assess kidney function. Usually in smaller rural public hospitals, but sometimes even in our tertiary centers. HbA1c monitoring is done infrequently, and treatment of acute kidney injury in our intensive care units become challenging when arterial blood gas machines are out of order. We have often resorted to the use of hemodialysis machines decommissioned in other developed countries. And even when machines are purchased, technical support for breakdowns is understandably challenging due to geography.
Because of the huge burden of kidney failure and patients' immediate need for dialysis, it's easy to get distracted by tertiary services and lose sight of primary health, prevention and early detection of kidney disease.
For the past 5 to 6 years, we have been advocating for the early detection of kidney disease through performing urine dipsticks and measurements of proteinuria in those who are at risk of kidney disease. After much effort, thanks to collaboration from stakeholders, evaluation of urine protein has become incorporated in our national NCD and CKD guidelines.
The sustainability of any health program depends on multiple stakeholders. These include the role of government and its commitment to funding and infrastructure development, the perception and compliance of the end users, the patients, the role of non-government organizations, but the most important ingredient to a sustainable health service is the commitment and dedication of its health champions. When we look back at history, we see that dialysis was attempted in Fiji in the 1960s, the 1980s, and in the early 2000s there was an attempt to set up a chronic peritoneal dialysis service. And all these attempts failed because we lost the key people who were driving this service. Doctors, nurses, and support health staff form the backbone of any health service. Services can always be upgraded or downgraded based on the amount of resources available, but services cease to exist when we lose the champions who drive it.
So equitable healthcare delivery is challenging in every country, and it's particularly challenging for medical conditions which require expensive treatment like dialysis. Over the last 5 years, through the support of government, we've been able to set up nephrology clinics in many public facilities and in some private health centers as well. But the biggest advancement we've had in the recent years is government providing a subsidy to disadvantaged people requiring dialysis. 3 years ago, government would subsidize about half of the cost of dialysis. Now, dialysis is provided completely free in our public system dialysis units. In addition to this, government also supports dialysis in private centers where patients pay as little as $25 per session. Our aim is to make kidney health as accessible and as equitable as possible. And in the last few years, we've been setting up satellite units that allow people to be able to come and access that healthcare. With the setting up of our peritoneal dialysis program, even patients who are living in rural and remote areas can now access treatment. The challenge to the world is to make healthcare as equitable as possible throughout the globe. Out here in the Pacific, many of our people are disadvantaged.